Good morning, everybody. Wakey, wakey. It's time for Morning Glory. My name is MC Kalia, and I'll be your captain for the next 1 hour, 30 minutes. Let's have this conversation going. Good morning, everybody. Wakey, wakey. It's time for Morning Glory. My name is MC Kalia, and I'll be your captain for the next 1 hour, 30 minutes. Let's have this conversation going.
Ruto Tophill Hospital, a brain and spine specialty hospital dedicated to providing extraordinary care through competent doctors and other medical personnel from premium institutes with knowledge on the latest and exceptional medical technologies. With a capacity of over 70 operational ward beds, over 30 specialists and consulting doctors, Tophill Hospital is a modern level 5 facility equipped with 12 state-of-the-art ICU HDU beds and 2 modern HEPA-filtered theaters with laminar airflow. Our aim is to provide comprehensive quality services at an affordable cost to the community, which includes but not limited to neurosurgery, radiology and diagnostics, MRI, CT scan, X-ray, ultrasound, endoscopy, ECG, EEG, pediatric cardiology, physiotherapy, orthopedics and trauma, pharmacy, laboratory, theater, ICU and HDU, obstetrics and gynecology, general surgery, maternity, psychology, psychiatry, comprehensive wellness checkup, dialysis and urology, oncology, dental care, ENT surgery, nutrition and dietetics. For ease of movement and transfer of patients, the hospital has 2 modern critical care ambulances equipped with ICU facilities and available 24 hours. Tophill Hospital is located in a serene environment away from noise and has a cafeteria with fresh, nutritious foods, not forgetting ample parking for all clients. Tophill Hospital is NHIF accredited and accepts medical covers from a number of insurance companies. If you're looking for the best customer care and patient experience and to be attended within the minimum waiting time possible, reach us through the website www.tophillhospital.com or call 0782 121214, or you can also call 0782 900090. You can also email us through info@tophillhospital.com.
The 22nd day of February 2023. Welcome to the Morning Glory Show. Remember, this is the most comprehensive talk show in Kenya today. It is Wednesday, and when it's Wednesday, it is the healthy, wealthy, wise edition of the Morning Glory Show. My name is MC Kalia, and for the next 1 hour, 30 minutes, we shall just be discussing matters health. And today, Dr. Kevin Ruto from Tophill Hospital is here to help us understand common the word is going away. I'll have to take this one slowly. Okay, so neurological condition, common neurological disorders. I don't know why the word has actually evaded my brain, but then nonetheless, welcome to the Morning Glory Show. And before you go far, allow me to remind you that we're coming from one of the best studios in town, the Dawi of Freak Photography. I use the word there because, manze, we are so famous now. So this is the Dawi of Freak Photography, the place where you get some nice experience in front of the camera and beautiful memories at the end of it all. And if you will be in this region and you need those nice photos, don't go elsewhere. Just ask for Zion Mall. And when you're at Zion Mall, then make an effort to make your way to the ground floor of, or the basement rather, of Zion Mall. And that's where we are situated. Also, iwapo ungependa kupiga luku, iwapo ungependa kung'ara, then consider walking into D-Square. But then, if you want to get the heartbeat of fashion, if you want to learn fashion, then also we have D-Square School of Fashion Design and Tailoring just for you. Very pocket-friendly school fees, well-trained tutors, and at the end of it all, D-Square Fashion House is just next to it. So that means that immediately you learn how to, as you learn to do garment making and all that, you have a place to practice. So consider, if today you have passion for fashion, then D-Square School of Fashion Design and Tailoring should be the place to go. Now that word, once again, neurological conditions, I have to say it so many times today. Daktari tutakuwa ananisaidia, tunaenda hivyo elezea hivi. It's coming up once again. So we're actually trying to look at the most common neurological condition or disorders rather, and we have epilepsy, we have brain tumors, and then also we'll talk about meningitis. Dr. Kevin Ruto is here already. He's been here before. He's now a resident panelist on this particular show. Karibu sana, say hi to our people now.
Okay, good morning subscribers, and welcome to the Morning Glory Show. It's me once again, Dr. Kevin Ruto from Tophill Brain and Spine Hospital, Eldoret. It's been an honor always being here to talk about our health, and also to always advise us on how we can live healthy and wise by the end of the day. Welcome once again. We'll be talking about epilepsy, we'll be talking about meningitis, and common neurological tumors that we'll be covering just but a few. It is a wide topic, so we are going to cover the much that we can as of today. Okay,
thank you so much for that. And actually, thank you also so much for always making time to be with us. If you're asking yourself the direction to Tophill, what was that Tophill iko wapi? Now, I told you Tophill is one of the most accessible hospitals because almost all the roads in Eldoret lead to Tophill Hospital. Starting from, when you're coming from Kisumu, Kapsabet Road, then or Kisumu Eldoret, just around Nairobi Road, thereabout, you'll see a signpost 1.8 kilometers towards Tophill Hospital. Tophill Hospital is actually situated just next to Bomain. So that means also when you're coming from Nairobi, you don't have to come to town. No, there is a way just that leads you just immediately after Poor Place. There is a road there, a branch on your left that leads you towards the temple around MTRH, and around there you'll see another signpost showing you that you can actually access Tophill Hospital from that road. So also Nairobi Road on the other side, maybe if you're coming from Nairobi and you decide to branch at around Annex, there's a petrol station there, I think Simba petrol station. Just on the left also, you are able to access Tophill Hospital from that particular road. So I told you, this is one of the most accessible hospital, just situated also in a serene environment, good for healing. And if you're looking for the best consultants, you're looking for the best medical practitioners, then they are best in Tophill Hospital. Now, interesting facts about neurological conditions, and I just want to talk about epilepsy because that's the first one we'll be tackling. You'd imagine that epilepsy is the most common neurological disorder worldwide. So it contributes actually to 1% of the global disease burden. Now, this is the biggest bit of it, that low and middle income countries bear the highest statistics of epilepsy. Now, Dr. will be talking about this, but then it is also important for you to know that the sub-Saharan Africa bear the highest statistics. Now, nonetheless, let's talk about Kenya. Now, in Kenya, epilepsy is more prevalent due to insufficient diagnosis and a large treatment gap coupled with lack of appropriate infrastructure in hospitals. And also interesting to note is that there is a survey that shows that 12.7% of people today in Kenya are at the risk of maybe contracting or having epilepsy. Daktari will tell us why, and Daktari, right into it. Why is it that it's so much in sub-Saharan Africa and not in the other developed countries? And of course, we'll start by defining what epilepsy is.
Okay, thank you very much, MC, for doing your thorough homework as far as epilepsy and rest of neurological conditions are concerned. You seem to have so much details as to the prevalence and even the incidence in the sub-Saharan Africa. So to begin with, we are going to talk about what really is epilepsy. So just for the benefit of the non-medics, I'd want to tell you that the human body is made up, not basically the human body, the human brain and the nervous system. It's more like an electrical circuit, okay? Or those people call it a circuit. So it's a circuit of electrical impulses. Some impulses being generated from the brain, then they are sent all the way down the spinal cord and to the nervous system. That is how your brain gets to control the rest of your body. So it's basically like the CPU sending some messages to each and every individual part of the body. And these are electrical impulses. So then, what is epilepsy? Epilepsy, before I get to defining epilepsy, there is something called a seizure. Other people call it a fit. So whenever there is a particular damage of some point in your brain, the threshold for which these electrical impulses are generated is lowered. So it means any slightest trigger is going to stimulate an electrical impulse that is going to be sent to a particular point of your body. And what are you going to get? You are going to get this sudden jerky movements of that part of your body because of what? The lowered threshold of generating the electrical impulse. So that is basically what a seizure is. It's an abnormal impulse generated from the brain due to some damage in that area of the brain. Now, that now leads us to the definition of what epilepsy is. So epilepsy, therefore, it's a chronic. Chronic means it's something that has been occurring over a long period of time. Synchronized and abnormal impulses that are generated from the brain and sent to the particular part of the body, either focal or generalized. And what do you get? You get these abnormal movements of that particular part of the body. Usually for us to label you an epileptic patient, you need to have repeated episodes of the same. So mark these words. Chronic, it's something that has been there for a long time.
Then
Number 2, it's abnormal. Number 3, it has to be repeated episodes. And it has to have something called an unidentifiable provoking factor. There is no consistency. So those are some of the things. And it has to be at least 2 to 3 times within a year. That is why now we say that you are an epileptic what? An epileptic patient.
When you talk about now repeated and chronic, that means that, and you also mentioned something that it is unpointed to something. So then that means that maybe is there any specific or rather known cause then of epilepsy, or then inamaanisha bas labda everyone gets it for maybe different reasons, and having said that now it is something that actually happens in the brain, does it mean that different causes may interfere with the brain now that you have epilepsy for different reasons?
Exactly. So that leads us to what are some of the risk factors, or what are some of the things that may end up making you experience these abnormal episodes of convulsions later in your life, okay? And by answering that question, you will also be able to answer the reason as to why you will find that in the sub-Saharan Africa or in Africa, the incidence is on the higher side. So number one, we have triggers, and these triggers usually we classify them based on different ages. We have the neonatal period. The neonatal period means this is usually the period during late pregnancy to the time of delivery and the first 28 days. That is the prenatal period. Then from there we have the ages, the childhood ages. Then we have the adolescent ages all the way to adulthood. Then we have in the elderly age group. Because epilepsy can get to you at any point of life, okay? So starting with the neonatal period. Neonatal period is during that period when the mother is pregnant towards the point of delivery. So in case a pregnant mother develops any sort of complications during birth, what we call whether there is birth asphyxia that we talked about initially, when there is a traumatic delivery, when they get infection during that period in time, okay? That by itself, or whether this child who is born develops an infection, yeah, during that period of the neonatal period, the chances are this infectious process can lead to some particular brain damage, which might manifest itself as repeated convulsive episodes later in the lifetime. Okay? As you progress further to childhood and into the adolescence, there are infections that can affect the brain. Okay? Some of these infections include meningitis. Others of these infections include things like malaria, cerebral malaria. We also have other things like what? Malformations, congenital malformations, which cuts across. Okay? There is an abnormality during brain development. So you are able to, you can get this brain damage. Other things are metabolic disorders. When I mean by metabolic disorders are derangements. In the human body, you have different, what we call electrolytes. Electrolytes are like ions, the sodium, potassium, magnesium, phosphate, and all that. When there is that metabolic derangement, and even glucose and all that, whenever there is that metabolic derangement, it can lead to get what? A brain damage and an abnormal firing. Further, as you go and progress into the adult life and the elderly, there are things now that become more common. A majority of them being, another thing is infections cut across. Trauma cuts across. But among the elderly or among the adults, the majority of the risk factor or the major contributor is trauma. You've been riding in a border, you hit your head on somewhere, you sustain some brain injury, so that it heals, that part of the brain gets misfires abnormally. Then later on now you start getting what? Brain tumors. So brain tumors can also be what? A trigger of abnormal firing. So that's cut across. Now let's go back to the question of why is it more common in the sub-Saharan Africa? As you have said it right, in the sub-Saharan Africa, our health system as far as caring for our mothers during the prenatal period, which actually is the biggest percentage of contributing factors to later on developing epilepsy. We haven't reached the standard. Okay? You will get to a maternity center, some place like, I wouldn't want to mention any name. You find like 100 mothers delivering, or let's say 50, under the nursing care of how many? Maybe just like 10 at most of healthcare professionals. What do you expect when this happens, therefore? We are not able to provide good services to ensure that these mothers do not get complications during delivery. Okay? That is one reason as to why it is more common in Africa. Number two, our incidences of trauma, accidents, border, and
Are higher.
They are more on the upper side. Number three, infectious processes, meningitis, HIV, okay, malaria. All those are in the higher side when it comes to the sub-Saharan Africa as compared to the first world countries. All these factors contribute to a majority of the things that might lead you to getting what? This brain damage. And that is why you have more incidents in the sub-Saharan Africa.
And okay, somebody asking a very quite I would say a question that comes in almost when you talk about every condition. You realize that she's saying that there are families which are associated with epilepsy. Maybe you see the father has epilepsy, then also you find the children having epilepsy. Is it something that can be passed down genetically, or is it maybe that there is some infection that also affects the brain running through the family?
Epilepsy transmission in family is hereditary. Yeah, there exists some component of that. There exists some component of heredity of epilepsy in families. That is very true. Then it is even worsened further by the risk factors that I've mentioned to you. Yes.
And that takes me to my next question, where are there people who have a higher risk of getting or contracting epilepsy than others in terms of genetics, and also in terms of maybe in terms of environment? Yeah.
So, are there people who are at a higher risk in terms of genetics?
Not even genetics, but also environment. Are there people who have, from where you sit, maybe are there regions? Okay, we've talked now about sub-Saharan region, but then are there areas in terms of workplace and all that report more epilepsy compared to the others?
As far as geographical occupations and all that is concerned, there is really no clear cut as to that incidence. But we look, that's the same way, whenever we are classifying, just as I mentioned, we look at the age groups and the complications, things that lead you to contracting it. It is not as, initially we were talking about, in other diseases we've been talking about an interplay between environment and genetics. But for these cases of epilepsy, at times it's less of environment, at times it's less of heredity, and more of just exposures or triggers and the risk factors that cause what? Brain damage. Okay? So it's more of that. So that means therefore that it tends to cut across different classes of individuals, our different workplace and all that. There is no that clear cut.
And also, we've seen these things usually happen in the seizures usually happen in the most, I would say, unexpected ways. Some of them happening in cars, some of them happens in the middle of the road, and so many people don't know how to handle it. What should I do? Maybe when a patient in front of me maybe falls down, and how do I even know that this kind of seizure could be epilepsy, and what could I do to them?
Good. So, for the benefit of our viewers and for the benefit of answering your question, epilepsy, we've talked about what are the common things that cause brain damage and that might lead you to getting what? Epilepsy. So basically, these causes that I've told you are things that cause brain damage and makes you to have a low threshold of convulsing. Then there are now those triggers, the common triggers. So those were the risk factors that cause brain damage. Now we have the common triggers. You already have the brain damage, but there are now these common day-to-day triggers that now make you to get these episodes. Number one, alcohol intoxication or alcohol withdrawal.
Alcohol iko kwa ugonjwa zote.
Iko kila mahali. Number two is an infectious process. You get an infectious process. Number three, fever. You get a fever. Number four, even lights, blinking lights. Okay? You get a seizure. Because already your threshold of firing is on the lower side. So any slightest trigger will lead you to do that. Fatigue, kuchoka. Okay? Just gets you a convulsive episode. Another thing is deprivation of what? Sleep. You do not sleep well, and then stress. So those are now triggers, things that make you now fire abnormally. Now, let's now go next to different kinds of epilepsy so that you can get to know how you can manage in case a patient gets dizzy. So we have partial seizures. Then you have generalized seizures. A partial seizure is a seizure, just a small part of the brain is affected. So when it fires, it just affects a particular part of the body. So you might find maybe the part of the brain that is affected is the part that controls movements of maybe your limbs, maybe your hands. So you'll get probably just a patient
Mtu anaguzaguza mkono tu
yes,
kiasi.
unaona. Or maybe it's just one leg, just one side of the body. That is what they do. Blinking eyes, rolling and all. So those are partial seizures. They are not generalized, and rarely do you lose consciousness whenever you have a partial seizure. So they are usually very much aware of what is going on. Okay. Then now we have this what you call generalized seizures, of which generalized seizures are of different kinds. Generalized seizures are these seizures that affect now. They are diffuse in nature, so they affect. I would say they affect literally every part of the
body.
Every part of the body, because it affects a majority of the part of the brain. So what these patients present with, there are different classes. We have what we call tonic-clonic seizures. Tonic-clonic seizures is where now these patients ends up convulsing, rolling the eyes, all body rigidity, then relaxing. So those are tonic-clonic. Then we have just myoclonic seizures, where one patients just have rigidity of the muscles, or tonic seizures. Then we also have others like absent seizures, which is also common in children. They are doing something, maybe they were taking tea, then at some point they tend to forget that they were doing something, so they go blank for some time, then they come back. And when you ask them whether they have experienced anything, they are not even aware that anything happened. Those are what we call absent seizures, so they go off completely. Okay. Then other forms of seizures. We even have catamenial seizures, which are associated with what? Menstruation in what? In women. Yes. So those are different only. So as far as the majority of the seizures that usually affect people and they end up with what I call hazardous presentation, or they might end up harming themselves, is these generalized seizures, unlike the partial seizures, because partial seizures, there is that consciousness. For
They are aware of what is happening.
Aware. But for these others, generalized, they might not be aware. But then, those patients who've been experiencing this repeatedly, there's something called an orifice. An orifice, for a patient who has had epilepsy, they can always tell you that they know when they are about to experience it. So either they get some funny smell, either they get this funny headache, some fatigue, okay? Just feeling of some impending thing. So they can always tell for a patient who's experienced it repeatedly. And you'll find most of them going to some place, lying somewhere, waiting for it to happen. That is now the ictal phase. Then the post-ictal phase, now that is now when they lose that control, and maybe they even end up biting their tongue. In case they were driving, probably they find themselves have hit themselves on something. Or in case then the others fall into deep sleep, others even lose their bowel or urinary control. That is the post-ictal phase. But for them, those ones can feel the initial orifice. Now, what do you do whenever you find a patient who is actively convulsing outside an hospital setup? Number one, safety is the most important. You do not want them to harm themselves. So it is, you get them to a place of safety where they can convulse without harming themselves, without hitting themselves on, or without falling on fires. A majority of the patients who come, you find they are cooking. So whenever you cook, when you are cooking, particularly, the fire itself consumes oxygen. When there is some form of hypoxia, so they tend to trigger that episode. So you find a majority of them, they come with burnt faces. Okay? So you want to keep them away from driving. We discourage them from driving. So get them to a place of safety. That is number one. Number two, do not attempt to restrict. Okay? You want to tie them down, to press them down and all that. No. You just leave them to do what? To convulse. Okay? Because basically these convulsions usually just take and then they relax. Okay? So just get them to a place of safety. There is something called recovery position, which maybe we can talk about it later. Once they finish convulsing now, therefore, then now you can bring them to hospital so that we can ascertain. So priority number one is safety. Whenever they get to hospital, we usually want to address the most common triggers of a convulsive episode. We want to check how is their sugar level, how is their oxygen saturation, how is their, do they have any infection that could have triggered them into this, okay? So those are some of the things that we want first to address. Those ones you cannot address at the roadside, okay? Yeah.
And thank you so much for that, Daktari. For those who just joined us, this is the Morning Glory Show. It is the most comprehensive talk show online today. We are talking to Dr. Kevin Ruto from Tophill Hospital, taking us through common neurological conditions. We are currently tackling epilepsy. And by the way, if you just joined us, we've actually tackled quite a bit of it. Maybe you can continue with us, then later you can also come and review the link, because the link remains on the page. You can also always feel free to visit Tophill Hospital. It is just next to Bomain in Eldoret. So Elgon View next to Bomain in Eldoret. That is where Dr. Kevin Ruto works and comes, and that's where you can actually get to see him on a one-on-one. And now you've talked about what someone should do when you find them, especially on the roads. And actually, when you talk about experiences of people having fallen into fires, I think they're quite common in our society today. Now, let's talk about treatment. Is there any permanent treatment for epilepsy? And then also always the issue of cost and the issue of insurances would then come in. How many insurances, or how willing are insurances to cover epilepsy? How expensive is it to treat, and is it treatable?
Epilepsy is not curable, but we've seen some particular individuals get to some point where they do not experience episodes. Okay, that is number one. But it is treatable, because maybe just to take you back a bit, by the time you say that a particular patient is epileptic, you first need to have ruled out everything else. They do not have a brain tumor. They do not have an active infection. So it is something that you needed to have ruled out all that. So that the only thing therefore you'll be doing is just controlling what? The seizures. So we have medications that we use to control seizures. Different classes for different kinds of epilepsies. For different kinds of convulsions.
Okay.
Okay. So we have different medications. Our target usually is we get to give the lowest doses that give us maximum control. Okay. So for example, I'll give you an example of something like a generalized seizure that maybe you've initiated the patient on something like Tegretol, carbamazepine, okay, or lamotrigine. So you want to give the lowest dose that will at least control your seizures. So if it means by giving 200 milligrams of carbamazepine, for example, controls your seizures and your patient does not get repeated convulsions, then that is it. You just maintain it at that. But in case you give 200 of that, then they still experience the same convulsions. You'd want to
go to a
slightly higher dose that will be effective. Once you've achieved that, you want to maintain now this patient on that particular dose for some length of time. Okay? Usually you can never go for, a majority of them go for a lifetime. But at some point, whenever we notice that this patient has not been experiencing convulsions for some time, we now start coming down slowly, okay? To a point where, in case we notice that a patient is no longer getting nini, we now do maybe alternate day, then maybe we need them off medications for some time. Whenever they do not experience for like 5 to 10 years a convulsive episode, then now we declare them cured of epilepsy. But rarely do we get there, that point of cure. So a majority of them are usually just on those medications for some time. And for those who do not respond to first-line medications for a particular group of NINI, we always have the second line, third line, and even fourth line for different. Yeah, and we also have options of combining these medications to give. Insurances and covering for epilepsy, a majority of them, including national health insurance, covers an all other nini. It's not expensive to treat epilepsy. So there is no reason whatsoever as to why an insurance company would not want to cover what?
Epilepsy.
For epilepsy. So yes, a majority of the insurance covers, including at Tophill Brain and Spine Hospital, which I must always mention. Because it is what feeds me. So we do offer medications, and we actually, I think we are the leading in Eldoret, covering for a majority of the patients who are with convulsive disorders, brain disorders, pain, and we really cover it so well. Yeah.
Okay, thank you so much for that. And now, as I think we are now closing in on epilepsy, people would ask in terms of, you've mentioned alcohol. Maybe are there any other environmental factors that people need to control in terms of food, in terms of, especially in terms of food, that is diet, and also in terms of environment? What are some of these things that epileptic patients should keep off from?
So, means we are going back to common triggers. Okay. So common triggers, number one, we said fatigue is one. You've deprived yourself of so much sleep. You're working so hard. Then already maybe you have had a convulsive episode in the past and all that. So fatigue. Rest. They say at least an average human being. Of course, I know some people will not agree with me, but an average human being is supposed to sleep for 8 hours. But for the sake of hustling, probably 6 hours is supposed to be the least that you can. But take breaks, relax, engage in activities. Do not stress yourself. Number two, alcohol. Let's avoid. Our friends, I don't know, I won't mention names. Okay. Number three is for patients who have epilepsy, you usually just want to tell them to avoid risky things that are risky that can endanger them in case they get this episode, like driving. We usually discourage them for driving. I think I've ever seen one case of an epileptic patient. It was a father who had not experienced a convulsive episode for some time and was in a car with the daughter. Okay. But then got this convulsive episode with the foot on the accelerator. Okay. And that is how he just ramped into the house, and because you at that point in time you do not have control. So in case you would want to get what? A chauffeur, someone who can be driving you around, because you do not. Number four, adherence to medication for those people who've been diagnosed. Adherence, just as I always say, adherence is what? Is key to averting complications.
You got me off guard.
Yes. Other things that you need to avoid, just live healthy. Eat well, exercise, and basically that.
Okay.
In case you have an infection and you don't feel well, just go to hospital. Let's treat you.
Basic guidelines. Okay, and as we close in, then people asking about side effects of the medications that are taken in for epilepsy. Then I think that would be enough for today about epilepsy. Of course, I've told you, if you need to see Daktari, is always at Tophill Hospital. Once you're there, it is the mantra is actually exceptional technology, extraordinary care. So you need to visit them to experience the extraordinary care. Nonetheless, Daktari, are there any adverse side effects for the drugs taken for epilepsy?
Yes, there are. Different kinds of these drugs have their own different side effects. Okay. There are those common side effects for any drug: nausea, feeling vomiting, excessive sleep. For example, some of the drugs that we usually use for epilepsy tend to they are sedative in nature, so they tend to make you feel more sleepy than any others. And others, there are even those that cause bone hyperplasia, things like phenytoin and all that. So what we usually target is, we usually want to target the use of drugs that have lesser side effects. That is number one. Then number two, as I mentioned earlier, you want to use the least dosage that gives you maximum effect, control. So by so doing, when you use a drug that has lesser side effects and you maintain it at a lower dose, it means therefore you are trying to control the side effects that are associated with it. Yes.
Then also you'd say that the good outweighs the bad.
Yes.
Okay, thank you so much for that. I think we have conclusively handled epilepsy. Of course, once again, if you need daktari, always make your way to Tophill Hospital. Now, let's talk about meningitis. Hope that is the right spelling, not rather the pronunciation. Meningitis, it is another neurological condition that is eating a lot of people, and I don't want to give the statistics for the interest of time. Daktari, what is meningitis?
Itis, to start with, in medical terms, means inflammation. Inflammation is kuvimba. It's an inflammation. So whenever you hear anything, itis, sinusitis, meningitis, it means there is an inflammation. Meninges, as you see I would say your head, your skull, there is the bone, this thing here, is skull here, you know. But just below it, there are cushions that cushion the brain. There are like 3 of them, the dura, the pia, and all that. So those are cushions that, then we also have some, yeah. So whenever you see the car, they usually
ni kama zile mount za engine zile. Usually between kule chini.
Exactly. So those are the cushions before you get to the brain. So those are what you call meninges. So then meningitis is inflammation of the meninges. What usually causes inflammation? Inflammations usually are caused by infectious processes. Bacterial, viral, or fungal infections. A majority of the meningitis are due to what? Bacterial causes. A majority, especially for the immunocompetent. What I mean by immunocompetent are those people whose immunity is strong enough to, so a majority of them get bacterial meningitis. But whenever you're immunocompromised or your immunity is low for one reason or the other, of which for within our setup is because of HIV and AIDS infection, you tend to get other forms of meningitis, which usually are viral or fungal in nature. Okay, so meningitis is the inflammation or infection of the meninges. Meninges are the cushions that cover the brain. Now, if this infection spreads to the brain, okay, and causes inflammation of the brain, it causes what you call encephalitis. Encephal is brain. It's a term that we use to call the brain.
To refer to the brain.
Encephalitis. So in case you have both meninges and the brain, inflammation and infection, we call now that meningoencephalitis. Okay, so it's an infection of.
Okay. The terms inaniacha nikizubaa. Anyway, nonetheless, you can always rewatch the show. The beauty of this is that at the end of it all, we would want you to really understand what exactly happens in your body for you to get a particular condition. Now, we also want to move into, let's look at age first of all. Is there ages that are more prevalent than others? Then also, is there a difference in handling meningitis in maybe children and in the old?
The differences in age and meningitis are concerned are usually on, as far as the causative agents. Okay, the common causative agents for meningitis are what we call Neisseria meningitidis. Neisseria it's a bacteria that causes meningitis, so we call it meningitidis. It's a Neisseria meningitidis. Another thing that falls under that class of bacteria is Neisseria gonorrhoeae. That causes?
Gonorrhea, of course.
Gonorrhea.
No one forgets that.
So that is one. Yeah, so Neisseria meningitidis. But then there are other bacteria that cause meningitis, including things like streptococcus, which usually cause throat infections. They have also been shown to ascend to to the brain and cause meningitis. Now, those are the common ones. In the childhood, we even have listeria, which affects children and causes meningitis, and some things called torches need toxoplasmas and all that. That in the neonatal period. Now, as you grow older, the common ones are the ones that I've mentioned. In the elderly and in the immunocompromised, the causative agent now tends to change. Okay? For example, among the immunocompromised group, TB. You remember the last time I told you TB affects literally every part of your body except?
Except what? I don't remember.
It was except the nails and your hair. So if it's not your nail and if it's not your hair, every other part of your body can be affected by TB. It is actually one of the worst form of TB whenever it gets to cause what you call TB meningitis. It is fatal, it is deadly, and a majority of the patients don't. So it is usually common among the immunocompromised group. And what you call cryptococcus meningitis. You must have had cryptococcus meningitis among a HIV and AIDS group. So a majority of those patients get that. Then there are, of course, other causes. I don't want to give you so much. We have Klebsiella. Those are different bacteria and different fungi that cause meningitis.
And just close to the causative agents, then would be the risk factors.
So risk factor number one is, of course, age. Among the elderly, they might get Number two is immune compromise. Okay, whenever immunity being compromised, then you might get meningitis. Another thing is whenever you have, what I forgot to mention is whenever you have a traumatic brain injury. A traumatic brain injury, it means that something hit your brain and you get an open skull fracture, and then an infection spreads to your brain. That one can give you a meningitis. Then a majority of them are those. Then of course among the young is what? Infections during pregnancy and during delivery. Those are some of the risk factors that put you at risk of getting meningitis. Infection. Yes.
Okay, let's talk about management and treatment. Is meningitis, of course, I know it is treatable. What I don't know is if it is curable. Then also, is there also, when handling it in kids and when handling it in maybe adults, is it maybe, is there a group that is more easy to treat? Then also, in connection to that, we'll talk about the cost of treatment.
Is it curable? Is it treatable? We've said a majority of diseases
are treatable.
A majority of diseases caused by bacteria, viruses, and fungi are what? A majority
Treatable.
of them are treatable
and curable.
But those that we do not have, things like epilepsy. When we're talking about epilepsy, the cause is damage in the brain. So it is already a damage. Then triggers what? So those, we didn't talk much of viruses, fungi, and bacteria because those are just some of the things that cause brain damage, but they are not the things that
caused
the epilepsy. But for meningitis, you basically treat that specific bacteria. You treat that specific fungus. You treat that specific virus.
Hence cure.
Hence cure. Because once you dealt with it, the inflammation goes down, then you're cured. So yes, they are curable. Now, treating bacterial infections, usually it's much easier because sensitivity of bacteria we have a wide range of antibacterial medications that are specialized for treatment of various diseases. So treatment for bacterial meningitis in patients who are immunocompetent is easier. The one that is much more harder to treat is viral and fungal meningitis, including the cryptococcal meningitis and other fungal meningitis, and TB meningitis. TB meningitis, we usually treat it, I must have mentioned it the other time, we treat it for even up to 10 to 12 months. because it takes so long to
treat.
and its complications are even worse. Then fungal and viral meningitis are also harder to treat. Yes. So easier for bacterial meningitis, easier to treat immunocompetent patients than it is to treat viral or fungal among the immunosuppressed patients.
And what are the physical symptoms of somebody suffering from meningitis?
So meningitis being one thing that affects the brain and being infectious in origin, at times one presentation is headaches. So a patient, because it's inflammation in the brain, and the brain, it's within a socket. So whenever there is an inflammation, it gives you that headache because the space is so minimal. So headaches is number one. Number two, convulsions. Convulsions are what we talked about. Number three, hotness of body. Hotness of body, fevers and all that. Then number four, at times you can get what we call what? Neurological manifestations. Things like confusion, things like psychic episodes, things like what? Things like even loss of consciousness. Those are the common presentations for patients with meningitis. We say for any patient who presents with an altered level of consciousness, one. Number two, convulsions, episodes of undetermined cause. There is one test that we always say that. Learn to do what we call an LP. An LP is a lumbar puncture. Always target to take a sample, a CSF sample. CSF is some fluid that cleans your brain. I don't know whether you've heard of cerebrospinal fluid.
I think we've talked about it with Daktari at some kitambo. So I may have lost some details.
Yes. So it's something that that nourishes, cleans, and brings waste all the way. So all the way in the brain down to the spinal cord. So there is that fluid. So you would want to put some needle in from the back, take that sample so that it goes to the lab. It can be examined and you can determine what exactly is the cause of this episode. Is it a meningitis? And if it is meningitis, what kind of meningitis? Is it bacterial? Is it viral? Is it fungal? And we do what we call microscopic culture and sensitivity. Culture and sensitivity is you want to grow that specific agent, then you want to expose it to different classes of antibiotics or different classes of antiviral and see its response. By so doing, those organisms that respond to a particular drug, that is now the drug that you are going to take and give it to that patient so that the response is also going to be equivalently good. So we do not just throw in antibiotics or any medication.
So you just do it outside first of all? And
so initially, because once the patient comes in, we have something called empirical treatment based on the common organisms. Because I can't wait for 5 days for me to initiate treatment. So number one, I take that sample. Then number two, I start what we call empirical treatment. I give the common antibiotics that we've seen are responding to the common what? Common organisms that cause. So, for example, the common organisms that cause meningitis, as I mentioned, was Neisseria meningitidis and the strep. So we give antibiotics that cover that class of
as you now await the results.
As we now await, because we can grow anything from the culture that might not be responding to the common what? To the common antibiotics or the common drugs that we are giving. So once we get that result, now we are going to change the treatment to fit what? Whatever we've gotten from the culture results. Yes.
Okay, thank you so much for that. You're tuned into the Morning Glory Show. It is the most comprehensive talk show in Kenya today. And with us in studio is Dr. Kevin Ruto from Tophill Hospital, helping us understand our health better. If you just tuned in, we've already tackled epilepsy, currently tackling meningitis. Then we'll mention a few things about brain tumors. Just before we move to brain tumors, of course, I want to remind you that you can always find this link on our page and you can always review it. Also, Tophill Hospital is situated just next to Boma Inn. I've given you their mantra. It is that they offer extra. It is extraordinary technology. No, I'm getting it wrong.
Exceptional technology.
Exceptional technology, extraordinary care. Anytime they are free 24 hours. It is a level 5 hospital that specializes majorly in brain and spine. But then remember that it also has all the other departments that a level 5 hospital would have. If you're looking for the best consultants, if you're looking for the best medical practitioners, then Tophill Hospital should be the right place for you to visit. I think Bomain is a landmark. Tophill also is equally a landmark. So I won't be talking much about the ways that lead there. Of course, I've mentioned it earlier on the show. So make sure that you make your way to Tophill Hospital anytime you feel unwell. Now, Daktari, you've talked about treatment. What are some of the common mistakes that people make with this disease?
Common mistakes that people make. We say for any infection, a common mistake that you can make is, number one, missing it. Missing to identify it as soon as possible. Number two is because you've missed it, then you give treatment that is not responding to the same. So those are some of the common mistakes. Because if you miss it, for example, okay. Number two, when you give treatment that is not compatible with whatever you are dealing with, you would be basically exposing these patients to longer time of this infection and more complications. So missing it and that. Then number two is among the misdiagnoses. Some people have tended to, because of inadequate history and investigation, you miss out other things. Okay? You've been treating a patient for meningitis for a very long time. You've never done a CT scan. You've never done an MRI. And this patient has just been having a tumor that has been growing. Polypol. So what happens therefore? This tumor growth, you get the complications because tumors and this, it will also present with convulsions and all that. So you miss that time. Say that by the time you are noticing it is too late. Okay? It's too late and the tumor has grown and it has affected the majority part of the brain. So basically what I'm saying is proper history taking, proper patient examination, and proper investigation, tying the three. In the field of medicine, those are the key principles. We say, as far as patient treatment is concerned, history, taking the proper history as far as how the patient presentation has been and all that, covers for 70% to 80% of your diagnosis. So just being keen, listening to this patient and all that, you can be able to actually tell what this patient is suffering from. Then now you tie up your examination findings and what? Your examination findings and your investigations, CT scans, lumbar punctures and all that. With all that, it gives you a definitive diagnosis and it guides you your treatment. So whenever you fail in that, whenever you do not adhere to that, whenever you rush, chances are you might miss a lot of things.
Okay, once again, I believe that we've actually tackled much a bit of meningitis. Of course, those are the questions I had for it. But then unless there's any other thing you'd want to add for it, then you can take us to brain tumors.
If I want to add anything, I don't think there is anything much I'd want to add. Yes.
Okay.
Because
so then,
basically, meningitis is not something that is managed from home. Meningitis is an hospital diagnosis, and it is managed by clinicians. You cannot. I cannot tell you there is home remedy for there is no home remedy for meningitis. There is no, and all that. So. And the treatment, adherence, I'll still repeat, adherence, once you've been
adherence to medication
is key to
averting complications. Checky, bana. Checky, yeah. Give me that camera. Yes. Adherence to medication is key to averting complications.
So that is it. Then, of course, proper diagnosis.
Proper diagnosis. Okay, now take us to brain tumors. Of course, we may not get enough time to talk about these because, like as I can see already, time is giving us a run for our money. But then, of course, I believe that you can maybe talk about it in a general way. Then next time we may get enough time now to discuss it.
Brain tumors, or tumors of the brain. A tumor is a growth. Okay, so there are a lot of growths that can go in the brain, and the brain has so many parts. They can grow from anywhere. That is number one. Number two is that brain tumors, like any other tumor or like any other growth, can either be benign. By benign, it means not cancerous. By not cancerous, it means not spreading. So it can either be benign or malignant. Malignant means something that recurs and something that can spread. That is to begin with. Okay. Now, brain tumors, we have brain tumors among the children, then we have common brain tumors among the adults. There are a wide range of tumors of different histological types, okay, with different management options and all that. There are those tumors that affect children, then there are those tumors that affect elderly. Now, regions that tumors affect in the brain. Now, in the brain, we have different sections, but I'm just going to focus on two sections. Number one being supratentorial. Supratentorial, zile cushions nilikuambia, the ones I told you about the brain.
The
meninges.
Thank you.
Yes. Now, the brain has like, let me say, three parts. We have what we call cerebral hemispheres. One side, this other side, which is usually a reflection of each other with some dividing thing called the false cerebellum. Then as you come down here, there is some like something like a tent. Okay? So a tentorium that separates your cerebellum from your cerebrum. So cerebrum is the ones that is
part, yeah.
Then cerebellum is something here with the midbrain going downward. Okay, so there is something like a tent. What do you call the tentorium cerebri? So now that you call the posterior fossa, that section that is separated here is posterior fossa. Posterior means behind. Then we have the supratentorial, which is now tumors that affects the cerebrum. Among the children, a majority of the tumors are infratentorial. They tend to affect majority of the posterior. Okay. And among the adults, a majority of them are supratentorial. They are more on the upper side. Now, why do I have to say this? It's because whenever you are doing a diagnosis, of course, there are those common tumors that are benign. Examples are meningiomas. Meningiomas are tumors that arise from the meninges, and they are extraaxial in origin. So a tumor grows from the meninges into the brain, extraaxial. So those are some of the common ones. Okay. Among the infratentorial tumors, whenever you get an infratentorial tumor, a posterior fossa tumor in an adult or an elderly patient, the most suspicious cause of that is usually what? Metastasis. What do you mean by metastasis? It is usually a tumor that grows somewhere else in the body and spreads to the brain.
So that means that it happened elsewhere.
Yes.
Which means...
So probably you could be having a prostate tumor, a tumor in your liver, a tumor in your colon, if it's a woman, a tumor in your uterus, a tumor in your ovary. And it has really spread. We are in stage 4 and it has gotten to the brain. So you get those tumors. Okay? Those are posterior. So any posterior tumor, any posterior fossa tumor in an adult or an elderly patient, be suspicious of metastasis. Another cause. Look at it from a different angle. Unlike when you see it in children.
So which means that then for an adult, that means that at that time, that means a lot of time has been lost.
It basically means that we cannot do much. In other words. Yes.
Okay. Now.
Yes. Now, moving on swiftly as to these tumors. Of course, there are those tumors that, based on wherever they are, you'd want to, for any tumor, we always want something called histological diagnosis. Histological diagnosis is where you go for that particular growth, take it out, expose it to histological study, let it be studied, so that it can be determined what kind of tumor it is. Is it malignant or cancerous? If malignant, the better. A majority of the tumors in the brain, we target excision, if it can be excised. So we want to target removal of the whole of it, so that even as you expose it to histological studies, whether it turns cancerous or at least we've removed it. If it's benign, then it means we do not have to go back because we've already removed all of it for those that are removable. For those that are not excisable, of course, you'll just want to remove the much that you can, so that this patient does not experience symptoms. Now, presentation. How do brain tumors present, and how different are these tumors? How different are they from other
tumors,
from other conditions of the brain? Let me put it there from there. So, because it's a growth, therefore, it is going to affect particular things for which that particular part of the brain controls. I'll give example. Besides the common presentations being headaches, of course, and convulsion, which is a major presentation of a brain tumor. If, for example, it grows on something called a suprasellar, which a majority of them is what we call suprasellar. A cellar is just some space here. They tend to affect your eye. So a patient will come and tell you, I've been having progressive visual loss, blurring of vision. Imekuwa ikienda pole pole. Then I've been experiencing these severe headaches, okay, with convulsive episodes. That is supposed to tell you that this is something sinister. It is something that is happening slowly, and it is chronic in nature. If it's affecting any part next to your ear, okay, they'll tell you, I've been losing my what? My hii upande sijakuwa nikisikia nini vizuri as compared to the other one, okay? Or they tell you they are just hearing ringing voices. Kuna vitu tu zinapiga nduru, what you call tinnitus, okay? So then with these headaches, convulsions and all that, those are things called focal neurological deficits, okay? A focal neurological deficit is deficit in neurological function of a particular part of the brain because there is compromise of that part of the brain that controls that part of the body. Number 3 or number 5, actually we are in number 5, how it presents.
Actually umekuwa ukisema number 3, so nikasema sitasumbua daktari.
So if it has grown and it has affected a large part of maybe one side of the brain, some patients might present with what you might think could be what? Stroke. So I've been having progressive weakening of maybe the lower limbs or maybe one side of the body, okay? So those are things that you'd want to, whenever you find a focal neurological deficit, you want to be more thorough in your investigation, because you can highly miss it. So you want to do at least the more sophisticated now investigations, like what? Like CT scans and MRI imaging, which will help you pick those tumors. So those are some of the patient presentations. Next question, please.
Okay. Of course, it is a whole class. I think you realize from the comments when you're talking about such certain conditions, the comments become less. That tells you that it is a class for so many people. And Daktari, I think the biggest question that so many people ask is, of course, one, you've mentioned that there are some that are treatable, there are some that can be removed and all that. One is the prevalence. Maybe how often do you get patients, both now that you've said it's different in children and it's different in adults, how often do you get patients that present with brain tumors? Then also, how often do we get success stories?
So that is a very interesting question. I don't know how I can answer it, because there's a difference between how often I get to see these patients with brain tumors and how someone else.
Okay, no, maybe we'll talk about the prevalence generally. I'm sure you are aware of the statistics.
Yes.
Yeah.
So the prevalence generally, because if we are to talk about how often we see these cases.
Of course, at your hospital it is more because it's a brain and spine hospital.
Yes.
Yeah.
So, I would say in the recent past, for example, the prevalence has been on the rise. We see an average of up to like 3 to 5 brain tumors, okay, in a day. Average at Tophill Brain and Spine Hospital. Unfortunately, we are able to excise a majority of those tumors successfully with an over 90 to 95% success rate. Okay. That is good. You need to clap for that.
Okay, I'm just still trying to understand actually, because this is something that even yesterday I was we were deliberating whether to have it or not to have it because of the many questions that people ask, and with such conditions you notice that most of the questions zinakujanga inbox. Are you getting it?
Yes.
And you realize that maybe we need to do now a baraza for us to actually get to understand the whole of it. But then for the benefit of now my viewers, maybe what is it something that is environmental? How would they avoid getting brain tumors? Is there any obvious ways of making sure that we have a reduction of it?
Fantastic. So taking us back to, we talked about cancers some time back. I don't know. Have we talked about cancer?
I think it was with a different hospital, but then nonetheless we've talked about it.
We've talked about
I think,
cancers. Yeah. So cancers, different cancers have been on the rise in the recent past. We do not know whether they have been on the rise or we've had more sophisticated
technologies to
identify, and now we are able to get them and say that this is cancer. Probably in the initial, in the past, probably they were being missed out and people were dying without really knowing. So we are yet, but all that we know currently is that different kinds of cancers have been on the rise in the recent past. A majority of them being breast cancers, cervical cancers, prostate cancers. These cancers, as I mentioned, because of at times a majority of them present late, we tend to find even some that have metastasized to the brain. Okay? So that has contributed even more
to the increase
in what the brain cancers that you're seeing. Because the rest of the cancers are also on the rise. So that contributes. So therefore, if we are to talk about what can be done for us to lower the incidences, number one, as I always mention, is being able, education as to what exposes us to these different cancers, of which a majority of them are radiations, the food that we take, and all that. Then number two, screening. If we are able to screen for the common identifiable cancers, okay? You are at the age of, for example, you, a sweet 65-year-old.
Sweet 16.
Last time you were 18. Today you are 65, okay? You've been experiencing symptoms of urinary retention and everything, but you've never been screened for prostate cancer. A majority, if we can screen for that, because we know that it spreads, it can help us reduce cancers that spread to the spine and the brain. If it's among the women, we are able to screen for cervical cancers, we are able to screen for breast cancers. If we can screen for that and get it at an early age, we'll deal with it, and what will happen therefore, we'll not be able to to get an increase in metastatic stage 4 cancers that have gone to the brain.
So that means actually that for something to go to the brain, it must have stayed in the other parts of the body for so long.
So, as I mentioned early, we have primary cancers of the brain. Okay? Which over time I'll say we haven't noticed a rise in those cancers. There seems to be some, because a majority of them we do not have identifiable, we cannot screen for them, so we cannot really tell whether there has been a rise and all. But all that we know is there have been a rise in other cancers, not the primary cancers, and they are increasing the incidence of brain cancers, metastatic brain cancers. Okay.
So if people did then scans for these others,
for these
that can
others,
be
we might
scanned,
reduce the incidence of cancers that we get in the brain, so that it just leaves us with that bracket of the benign or the primary
cancers of the brain.
cancers. You get me? Another thing as to the increase in incidence of cancers is the increase in incidence of immunosuppression. It is very unfortunate to note that in the recent past, I think the latest study was, I think last year or the other year, they are saying there has been more than 50% rise in the number of HIV infections among the age group from 15 to 25 years.
I think that was 2020, in 2021, 2022.
Yes. So with immunosuppression, there are those cancers that are associated with what? Immunosuppression, HIV and all that, which unfortunately tend to spread very fast. So even that being said, therefore, it has also increased our what? Our incidence of getting brain cancer. So if we are able then to deal with things that we can deal with, it will help us reduce the incidence.
Okay. I would say that that has been quite conclusive. Of course, we must talk about the food, because you mentioned something about the food. Maybe, I know this could also take a whole classroom lesson, but then maybe, because anytime you talk about most conditions, then we'll talk about the food we take. We'll talk about radiation. Are these things we can actually control?
The food we take. We haven't identified any specific food that we take that predisposes you to cancer. Personally, I don't want to. Personally, I haven't come across food that we take, because even the junk foods just predispose you to obesity and all that. So it tends to predispose you more to conditions such as hypertension, lifestyle diseases. Cancer by itself, I wouldn't call it a lifestyle disease. Cancers actually are more of an interplay between genetics, which I also forgot to mention as a risk factor, genetics and environment exposure. Cancers, we have cancers that run in families, and actually a majority of the cancers run in families. Then now you come and add environmental exposure, of which majority of these environmental exposures, things like smoking, okay, are things like exposure to radiations, okay, things like some of the medications that do you have a nephrogenic? No, there is no. I think I haven't come across a drug that gives us a cancer. So those genetic and environmental factors. More genetic exposure. Yes.
Okay, so that means that basically screening for common types of cancers is what you'd prescribe to so many people that maybe as we go forward, then it would be nice that people scan for the other types of cancers to evade the cancers that are, how do we use the word, secondary to the brain.
Yes.
Okay.
Yes.
Unless there's any other thing you'd want to talk about brain tumors, then I'll be going for your parting shot.
Another thing I'd want to say is, just as I mentioned earlier, history, physical examination, and investigations are key as far as able to differentiate. Because you've noticed one thing in terms of presentation of all these things, headaches, convulsions, and everything. But you notice one different thing when I was talking about this one. Focal neurological deficit. I don't know whether you remember what I mentioned about a focal neurological deficit as to what I said. A focal neurological deficit is a deficit in a particular area of the brain that is in a
That will
particular
affect
area
that
of the body
part.
that is controlled by a particular area of the brain.
Yeah.
You want to be more aggressive. Now, lumbar puncture is a very good diagnostic test for TB. Not for TB, for meningitis and other infectious processes. But for a patient whom you've gotten chronic symptoms of the same with focal neurological deficits, and you've determined that, because another thing that gives you a focal neurological deficit is stroke, whether hemorrhagic or not. I don't know. Probably next time we can come and cover something on a stroke, with different kinds of stroke and how we can.
I think
tend to avoid it.
we've actually done it with Dr. Mwadime before.
Oh,
Yeah.
So it also presents with a focal neurological deficit. Whenever you are approaching that and you want to do an LP, you need to think fast. You need to investigate first. We always say do a CT scan and all that to rule out what you call a space-occupying lesion. A lesion is a space-occupying. A growth is a space-occupying lesion because it is occupying some part of the brain. Now, the brain is in a ball and socket. Not a ball and socket. Is in a socket, an enclosed socket with just very small openings. One of the major openings is something called foramen magnum here. Now, if you stick a needle at the back of a patient who has a space-occupying lesion, what is going to happen? You'll drain fluids into the CSF, and this brain is in a closed space under pressure. What is going to happen?
Of course, you'd see some profusely, if I use the word.
So number one. So of course, besides that pressure, that being able to release that fluid, some part of the brain, which is called the midbrain, is going to herniate through that small opening.
So it will tend to close there.
So itashuka. Because imefinyiliwa huko juu, so itateremka. Ikiteremka kidogo ifinyiliwe, just at that foramen magnum, there is a part there that controls your breathing. Okay? It's the respiratory centers in oblongata, medulla oblongata. Have you ever heard of medulla oblongata in primary?
Yeah,
Ukaambia probably your medulla oblongata is not working well.
Which actually was wrong, right?
So that part is the one that controls what you are breathing. So at times, in case you do not take proper history and you rush to doing an LP because a patient has come with headaches, convulsions, and you stick in, they herniate and you lose that patient instantly. So you lose that patient instantly from your LP. Yeah.
Okay, thank you so much for that, Daktari. Of course, as you said, this is a topic that we may not be able to complete the whole of it right now. And nonetheless, in your parting shot, maybe you'd give general advice in dealing with the neurological conditions.
My parting shot as far as dealing with neurological conditions are very serious. Anything that affects your brain nervous system is not something to ignore. It's not something to buy time. And it's not something that you can say, let's observe and see how you do at home. They usually need a professional medical attention. So those are it's not like asthma. It's not like all other things that we've talked about before. You can manage at home, you have blood pressure, you can do exercise. Whenever you can, it needs attention, medical attention by a medical professional. It needs a definitive diagnosis, okay? And it needs the proper initiation of treatment as soon as possible. So that is, a majority of those cases are basically for us and less for the community. Yes.
Okay, thank you so much for that, and thank you so much also always making time to be with us on the Healthy, Wealthy, Wise edition of the Morning Glory Show. Of course, I saw Faith Jerop, I saw Faith Chepngeno, I saw Mildred Zoom, I saw Queen Shi, I also saw, okay, now, I don't know if this is somebody because it is Marakwet East constituency. Okay, it's quite a long name. I don't think this is one person. Thank you so much, guys, for making time to be with us. I saw Kaltio Nasares and many more. Because for the interest of time, I may not have sampled some of your comments. You realize that today's conversation was actually quite I would say tumepatia daktari all the time to actually educate us, but then nonetheless I'll be in the comment section, of course, to continue interacting with us. Now tomorrow, being Thursday, we'll be talking about we'll be on the social square talking about SGBV. I think you've seen what the expose of what is happening in Kericho T estates. We want to actually talk about sexual harassment at workplace generally. So tomorrow we'll be having quite a big panel here to discuss that. So see you tomorrow. This is the Morning Glory Show. It is the most comprehensive talk show in Kenya today. Until we meet tomorrow, my name is MC Kalia.
My name is Dr. Ruto.